Hello, welcome back to Atropia Medic School. This is the second part of a two-part video series on cardiovascular emergencies. The last video I encourage you to watch first because it goes mostly over acute coronary syndrome type stuff. This one's going to cover a couple other ancillary topics that frequently pop up on the NREMT. So let's get started. All right, first question. Which of the following best describes an aneurysm? A, there is a hole in the ventricular septum. B, there is a weakened and dilated portion of a blood vessel. C, there is a blockage in a blood vessel. Or D, there is an electrical conduction issue in the heart. So take a moment, pick your answer. And the correct answer here is going to be answer B. So from last time we talked about acute coronary syndrome, that's what we're talking more about with C. There's a clot or a blockage in a blood vessel of the heart. So that's more ACS related. Electrical conduction issues in the heart, a variety of things can cause that. I'm not going to go into that, especially at the EMT level. Not really important that you know much about cardiac dysrhythmias and whatnot. A, there are conditions where there are holes in the structures of the heart, but that's not what we're talking about here. With a aneurysm, the blood vessel, it is made out of multiple layers, but generally speaking, it's getting dilated, it's getting stretched out, it's getting weakened. And this can eventually result in a rupture. So obviously not a good thing to have. Some people may have this as a genetic condition. Certain genetic conditions can cause these dilations to happen. For example, Marfan syndrome, Ehlers-Danlos syndrome are associated with this. Can also be caused by hypertension, atherosclerosis, or plaque buildup and hardening of blood vessels, things like that. All right, a 70-year-old male has sudden onset tearing chest pain that is radiating to the back. You note the following vital signs: heart rate 86, blood pressure 150/90 in the right arm, and 134/70 in the other arm. You should A, rapid transport, B, administer aspirin, C, administer nitroglycerin, or D, B and C should be given. Spend a moment, pause if you need to, pick an answer. And the correct answer here is going to be A, rapid transport. So what we're describing here is a thoracic aortic aneurysm. So we have a dilation of the aorta in the chest itself. So the aortic arch. We'll go into a second on a diagram about that. General rule of thumb, if it's not pressure like squeezing, elephant sitting on your chest, crushing, chest pain radiating down the arms or up the neck, chances are the test is not really going for acute coronary syndrome or myocardial infarction as an answer. We'll talk about at some other point some exceptions to those rules, but as it stands, this is not your typical ACS presentation as we talked about last time. And so we really need to think twice about giving those same treatments. So you certainly can do oxygen. Anyone who requires oxygen should not be withheld oxygen. But we're not going to do aspirin. We're not going to do nitroglycerin. Why is that? Because these two medications can potentially worsen any bleeding that's going on due to rupture of that aneurysm. Let's kind of demonstrate why here and what we're talking about. So let's start with the aortic arch, and that's what all of this is. This is the aortic arch. So classically in a thoracic aortic aneurysm, there is an area that is not only just dilating outwards, but also blood can kind of enter in between layers. So it will kind of we get plaque buildup, or we get some sort of calcification of the blood vessel, and as a result, let's choose a different color here. And let's say that we start creating a ballooned or dilated area of a blood vessel, and we're just letting blood enter in between those two layers. right? That's what we're seeing here. And over time, not only are we dilating the blood vessel outward, but we're also internally kind of creating a false lumen. We're creating a passageway that should not be, and it's going to balloon inside. And what ends up happening is, well, I've got these outlets off of the aortic arch going to the subclavian arteries as well as the carotid arteries. I'm now obstructing them. And so this is why in our classic test questions on aortic aneurysms in the aortic arch and the thoracic aorta, that we see those differing blood pressures between the arms, because on this side, well, we got good blood flow, but here we're inhibiting blood flow a bit because of this internal ballooning of that false lumen inside the aneurysm lesion itself. So that's why we see those differing blood pressures. With the rupture, or we've disrupted significantly the integrity of the aorta, that explains usually the sudden onset tearing chest pain. We need to treat aortic aneurysms pretty seriously because they do have a high morbidity mortality rate if they're not treated promptly. All right, let's go to the next question. Which of the following is not associated with an abdominal aortic aneurysm? A, pulmonary edema. B, pulsating abdominal mass. C, radiating back pain. Or D, decreasing lower extremity pulses. So, pause if you need to. Spend a moment thinking about an answer. And the correct answer here is A. So, a test-taking thing that I want to highlight here is this is what I like to call an inverse question. So they're asking kind of the opposite of what we traditionally ask in many test questions. We're asking you to pick the answer that is not true given the presentation. The NREMT and a lot of EMT tests like to do this kind of thing. So definitely something you want to kind of keep an eye out. The best way to avoid issues with these types of questions is spend, even if it's an extra moment or two, making sure that you're reading the question correctly. It's always better to measure twice and cut once than to rush through the question, not really pay attention to what you're doing, because you miss things here and there, and then you end up picking the wrong answer because you misread the question. Anyways, with an abdominal aortic aneurysm, let's go back to our diagram here. Let's kind of draw this out. So blood flow going through the abdominal part of the aorta, because again, it comes down, the aortic arch comes down through the essentially kind of the back of the abdomen, if you will, and it comes down and it comes down, it branches off into the renal arteries. It also has a bunch of other kind of branch offs going to like your mesenteric arteries and whatnot. Not super important here today. But let's say, regardless, this is just a diagram. It could be anywhere in the abdominal aorta. And let's say we start forming this dilated, weakened area of the aorta in the abdomen, and we start getting that dissection. We get that kind of false lumen forming because of all that plaque buildup separating the layers, and blood is going in between those layers now. Well, not only do we have a weakened area of this blood vessel that could potentially rupture eventually, but also because of that internal ballooning, if you will, if you want to call it that, we are reducing blood flow going down to the legs because the abdominal aorta bifurcates into the iliac arteries, and the external iliac arteries go to your legs. They help perfuse your legs. They become the femoral arteries. And you can feel a femoral pulse on people. So something that we may see is signs of poor perfusion in a patient's legs, like poor peripheral pulses. They're cool to the touch. They look kind of bluish or something. Seeing that we have this big old mass here, it's not unheard of to palpate a pulsating mass in the abdomen. And because often, much in the same way that we see that tearing chest pain, we may see this shearing or tearing abdominal pain that radiates to the back, kind of the same basic presentation, just in the abdomen. Again, we're not going to necessarily have like differing blood pressures here between the arms. We're talking about something much farther down, but this hopefully kind of illustrates why we see what we do with abdominal aortic aneurysms, and how this particular conglomeration of symptoms and how it presents should really kind of clue you in on, okay, they are probably talking about a triple A. All right, next question. A 50-year-old patient develops sudden onset pleuritic chest pain and shortness of breath 3 hours ago after a cross-country flight. Interesting. You note clear lung sounds bilaterally. The vital signs are heart rate 106, SpO2 88% on high flow O2, respiratory rate 24, and blood pressure 100/50. You are most concerned for A, deep vein thrombosis, B, pneumothorax, C, myocardial infarction, or D, pulmonary embolism. So spend a moment, pause if you need to, think of an answer. And the thing that we're going to get most worried about here is going to be a pulmonary embolism. So a pulmonary embolism describes a blockage of some variety in the pulmonary vasculature. And these blockages can be caused by a number of things. They can be caused by clots. So you could have clots in your lungs. It could be from an emboli from elsewhere, like an air emboli. That's certainly possible for a number of reasons. It could be fat from bone. So if we get bones broken, that can certainly cause it. In women, we may even see amniotic fluid postpartum or even like peripartum due to like something going wrong with the uterus and the placenta. So amniotic fluid may be seen in a pulmonary embolism in that specific population. So there's a number of things that can cause it. The number one thing that really clues me in on first that pulmonary embolism is something I should think of is sudden onset shortness of breath. Pleuritic chest pain, meaning that it hurts to take a breath in and out, not necessarily like in a specific spot always, but it may be in a specific spot, but just it hurts to take a breath in and out. If I'm not breathing, it doesn't hurt too bad. That's something we may see in pulmonary embolisms as well. Note here that they say that the lung sounds are clear. Generally speaking, lung sounds will be clear in pulmonary embolisms. This is not necessarily an issue with alveoli or fluid overload in the lungs. This is an issue if I'm not getting perfusion to part of the lungs. So this isn't necessarily a ventilation issue. What are some risk factors that we need to be aware of? So risk factors. Patients who are bedbound for a long time or post-surgical. These patients oftentimes are not necessarily ambulating, whether on purpose or they just have not been forced to ambulate. That puts you at risk for pulmonary embolism. Why? Because you're going to have stagnant blood in your legs that causes a clot, and that clot can travel elsewhere. Long flights or travel, kind of going in the same vein as being bedbound or post-surgical. You're not moving around very much. Your blood is remaining stagnant in your legs for a really long time. That leads to the potential for a clot that could travel elsewhere. There are people who have clotting disorders that could cause a PE to happen. And another one that we'll talk about some other time is atrial fibrillation. These patients are at high risk of having clots forming in their atria that can travel elsewhere. So we see one of those risk factors here, cross-country flight. With a pulmonary embolism, some other things you'll see is generally the heart rate will be up and the blood pressure, I'm not going to say hypotensive, but the blood pressure is not going to be super high either, or it's on the softer side. And notice here that the SpO2 is rather low. Now, they may or may not include this in a question, but do realize, like, if I don't have perfusion going to a part or most of one of the lungs, we can't exchange oxygen or CO2. So yes, I can get air in and out of my lungs all day long, but we're not going to exchange that oxygen and CO2. So the SpO2 may reflect that, and it may not be as responsive to oxygen therapy. I've seen this, actually quite a few times where even with CPAP, I only got someone's SpO2 up from like 75% to 85%. It didn't improve drastically. And this was a patient who ended up having like a COVID-related PE. So it does, we may not see it regularly in this level of extremes, but it does happen. Elevated respiratory rate, that makes sense. Because the patient's probably short of breath, they're trying to get more oxygen. What's one way we can get more air in and out of our lungs? Breathe faster. And we see here the kind of not great BP. It's not terrible, but not great. One thing I'll mention here is for pneumothorax, can pneumothorax present with sudden onset shortness of breath? Yes. Can it present with pleuritic chest pain? Yes. But the big thing here is we are not seeing the normal risk factors. So it's not that it's a bad answer. It's just I'm missing some stuff from like the classic presentation that really would drive home to me, hey, this is probably a pneumothorax. What kinds of things would I be thinking of? I'd be thinking of tall patients, more specific pain perhaps in a particular area, decreased lung sounds in some part. So I don't have, again, it's not a bad answer, but we're missing some stuff here. And meanwhile, I have these same complaints and a big risk factor for a PE. So hence why we will pick PE. All right, last but not least, a 30-year-old female complains of pain in her leg. She has been in a leg splint due to an ankle injury for the last 3 weeks. Her only medication is oral contraceptives. You note a swollen and erythemic lower half of the left leg that is tender with palpable pedal pulses. You are most concerned for A, arterial emboli, B, deep vein thrombosis, C, refracture of the ankle, or D, none of the above. So spend a moment, think of your answer. An erythemic is just describing significant redness, just to kind of clarify that. Pause if you need to spend more time thinking of an answer. But we are going to pick DVT here. So deep vein thrombosis, or DVT for short. This is where we get this is specifically a clot in a vein in the leg. Now, there are a lot of veins in the leg. Some of them are much more superficial. Some of them are much deeper. The superficial ones, they're not as worrisome. It's these deep ones, these deep, large veins that return a lot more blood back from the legs up to more central circulation. That is a little bit more concerning with the deep vein thromboses. Much as we talked about risk factors with pulmonary embolisms, the same risk factors are here too. Same risk factors as PE. So pregnancy can certainly induce this. Oral contraceptives, I want to mention that here. Oral contraceptives, or OCP for short. That is another risk factor for clotting issues. So whether or not you had clotting issues underlying, oral contraceptives can worsen that. That's just something good to know. This patient has been immobilized in some variety. They have a splint. So anything that is splinted does run the risk of having clots form in places we don't want clots to form. So we have a number of risk factors here for clotting issues to happen. And with a DVT, because the deep veins are getting blocked up, not the arteries, the deep veins, we usually still have perfusion going to the legs. There's still arterial flow going to the legs, so you should be able to find a pedal pulse, or you may have a hard time palpating it, but there's not going to be evidence of cyanosis, or you can use like a Doppler to find the pulse. That's also possible. There's no mention of her hurting herself since her ankle was casted or splinted, so I'm not worried about C here. That just doesn't make sense. If I was talking about an arterial emboli, I would see like a cold extremity with no palpable distal pulses, It'll have like a lot of numbness, tingling kind of thing, a lot of pain out of proportion with an arterial emboli. I'll write some of that stuff down here in a second. So with all that said, we're much more suspicious of a DVT. So cold to the touch, a lot of pain, no distal pulses. Those are some and some neuropathic symptoms. That's another common thing to see. Neuropathy. Those are all things that are more suggestive to me of an arterial emboli. And this kind of makes sense. If I have nothing going to that leg, it's not going to get perfused. It's not going to be swollen or anything. If I'm blocking up a vein, everything's backing up behind that blockage in that vein. So that's why we get the swelling and the erythema. So that is our 5 questions for this quiz. I think between those 5 questions, that covers a lot of material that you might see in cardiology or medical related questions on an EMT test somewhere. If you like the material, absolutely like and subscribe. If you have comments or suggestions for how to improve the content, absolutely leave a message, and we'll see you next time.